Hydrocephalus represents a fundamental disruption in cerebrospinal fluid dynamics, defined as accumulation of CSF due to an imbalance between production and absorption. Understanding the normal physiology helps us recognize when this delicate balance fails. Normal CSF production occurs at a remarkably consistent rate of 0.3 milliliters per minute, equivalent to 20 milliliters per hour in term newborns. This production rate is notably lower in preterm infants, reflecting their developmental immaturity. The total CSF volume in newborns reaches approximately 50 milliliters, with the majority produced by the choroid plexus located within the ventricular system. The absorption pathway proves equally critical. CSF normally reabsorbs into the venous system via arachnoid villi granulations located in the venous sinuses. When this production-absorption balance becomes disrupted, CSF accumulates and enlarges the fluid spaces, leading to hydrocephalus. Clinical manifestations depend entirely on cranial suture status, making age a crucial factor in presentation. In newborns with open sutures, the skull can expand to accommodate increased CSF volume, presenting primarily as macrocephaly, head circumference greater than 2 standard deviations above the mean. These infants typically show tense, bulging fontanelles and splitting sutures as external signs. Contrast this with children over 2 years, where fused sutures prevent skull expansion. These patients present with elevated intracranial pressure symptoms, including headache, irritability, vomiting, lethargy, and the characteristic sunsetting eyes appearance. Hydrocephalus stands as the leading cause of macrocephaly in neonates, making recognition and early intervention essential. The condition can arise from structural abnormalities affecting any point along the CSF pathway or metabolically from impaired absorption. This broad etiology requires systematic evaluation to determine the underlying cause and guide appropriate treatment strategies. The distinction between communicating and non-communicating hydrocephalus centers on the anatomical location of CSF flow impairment, with profound implications for both diagnosis and treatment approaches. Communicating hydrocephalus, also termed non-obstructive, occurs when CSF flow becomes impaired distal to the fourth ventricle foramina. The key characteristic involves proportional enlargement of all ventricles, because CSF can still move freely through the ventricular system but cannot be adequately absorbed. Post-hemorrhagic hydrocephalus represents the most common cause in neonates, developing when blood products cause arachnoiditis and dysfunction of arachnoid villi. Post-meningitic hydrocephalus creates similar pathophysiology through inflammatory debris blocking absorption pathways. Non-communicating hydrocephalus, the obstructive type, results from CSF flow blockage upstream from or at the fourth ventricle foramina. This creates selective ventricular enlargement above the obstruction site, with normal-sized ventricles below the blockage. The pattern of enlargement helps locate the obstruction anatomically. Aqueductal stenosis exemplifies classic obstructive hydrocephalus, accounting for up to 10% of pediatric cases. The narrowed aqueduct, normally measuring 0.5 millimeters in diameter and 3 millimeters in length at birth, creates lateral and third ventricular enlargement while the fourth ventricle remains normal-sized. Dandy-Walker malformation creates obstruction through fourth ventricular cystic transformation, partial or complete cerebellar vermisogenesis, and posterior fossa enlargement. This accounts for 5 to 10% of congenital hydrocephalus cases, with 75% of affected infants developing hydrocephalus. Chiari II malformation, uniformly associated with lumbosacral myelomeningocele, causes obstruction through hindbrain herniation below the foramen magnum. Importantly, head size may initially appear normal or even small due to CSF decompression into the myelomeningocele sac, but rapid expansion often occurs after surgical closure. The majority of fetal hydrocephalus proves obstructive in nature, emphasizing the importance of identifying structural anomalies during prenatal evaluation and planning appropriate perinatal management strategies. Aqueductal stenosis represents a classic example of obstructive non-communicating hydrocephalus, occurring when cerebrospinal fluid cannot drain from the third ventricle into the fourth ventricle due to congenital obstruction in the aqueduct of Sylvius. Understanding the developmental timing and anatomical constraints helps clinicians recognize this important cause of pediatric hydrocephalus. The condition develops between 15 and 17 weeks gestation, coinciding with the critical period of rapid mesencephalon elongation and evolution of the normal aqueductal constriction. During this developmental window, the normally narrow channel becomes pathologically stenotic, disrupting the essential CSF flow pathway. The normal aqueduct measures just 0.5 millimeters in diameter and 3 millimeters in length at birth. These remarkably small dimensions make the aqueduct vulnerable to obstruction from even minor developmental abnormalities. When stenosis occurs, cerebrospinal fluid collects proximally, leading to lateral and third ventricular dilatation, while causing compression of blood flow and restricting brain growth. Aqueductal stenosis accounts for up to 10% of pediatric hydrocephalus cases, making recognition crucial for NICU practitioners. The imaging hallmark shows enlarged lateral and third ventricles with a characteristically normal-sized fourth ventricle, helping distinguish this from other causes of hydrocephalus. The X-linked form, caused by L1CAM gene mutations, provides an important clinical clue that can aid early diagnosis. Thumb flexion deformity occurs in approximately 50% of these cases and can often be detected on fetal ultrasound, allowing for prenatal recognition and delivery planning. This genetic form emphasizes the importance of thorough neurological examination and family history assessment in affected infants. The clinical presentation of congenital hydrocephalus depends fundamentally on the cranial suture status, creating distinct patterns that guide both recognition and management strategies. Understanding these presentations enables early intervention and optimal outcomes. Neonatal signs center around the head's ability to expand in response to increased cerebrospinal fluid volume. The markedly enlarging head circumference often represents the first observable sign, requiring careful serial measurements plotted on appropriate growth curves. The anterior fontanel becomes full, tense, or frankly bulging, transitioning from its normal soft, flat, pulsatile character to a pathologically distended state. Cranial suture separation provides another crucial early indicator, with widening of the squamosal suture serving as a particularly useful sign for detecting increased intracranial pressure. This suture runs horizontally above the ear between the temporal and parietal bones, and its widening often precedes more obvious signs of hydrocephalus. The classic sun-setting eyes phenomenon results from upward gaze palsy caused by pressure on the tectal region. This distinctive finding, where the infant's eyes appear to look downward with visible sclera above the iris, provides a pathognomonic sign of increased intracranial pressure in the developing brain. Visible dilated scalp veins reflect the increased intracranial pressure and compensatory venous drainage patterns. These prominent vascular markings become increasingly apparent as the condition progresses and the skull expands to accommodate the growing CSF volume. Neurological complications arise from brainstem compression or ischemia, creating potentially life-threatening symptoms. Apnea and respiratory distress with inspiratory stridor indicate brainstem dysfunction, while depressed gag reflex and weak cry suggest cranial nerve involvement. Quadriparesis and dysphagia represent more severe manifestations requiring urgent intervention. The highest mortality occurs when stridor, apnea, cyanotic spells, and dysphagia present together, indicating severe brainstem compromise. Early recognition of these warning signs enables timely neurosurgical consultation and intervention to prevent irreversible neurological damage. Effective hydrocephalus monitoring hinges on understanding a fundamental principle. Ventricular dilation occurs before rapid head growth becomes apparent. This temporal relationship makes systematic head growth monitoring essential for early detection and intervention. Serial occipitofrontal circumference measurements form the cornerstone of assessment, requiring proper technique and consistent documentation. The measurement should be obtained with a tape measure firmly pressed against the scalp, including the occiput at or just above the external occipital protuberance and the forehead just above the glabella. Gestational age-adjusted measurements plotted on appropriate growth curves provide the clinical context necessary for interpretation. The critical observation involves detecting infants crossing percentile lines upward on growth charts. Normal head growth follows predictable patterns, approximately 2 centimeters per month during the first 3 months, 1 centimeter per month for the next 3 months, then 0.5 centimeters per month for the subsequent 6 months. Deviations from these normal growth velocities warrant investigation. Widening of the squamosal suture provides an early indicator of increased intracranial pressure, often preceding dramatic head circumference changes. This suture assessment requires systematic palpation during routine examinations, measuring any splaying or overlap in millimeters for accurate documentation. Fontanel assessment distinguishes normal from pathological findings through careful examination technique. Normal fontanelles appear flat or soft when the infant is calm and quiet, while pathological fontanelles remain tense or bulging even when the infant is settled. Sustained bulging when the infant is calm represents a red flag requiring immediate evaluation. Additional red flags include split sutures, which indicate significant intracranial pressure elevation, and any combination of abnormal head growth with neurological symptoms. Head growth velocity monitoring proves more important than any single measurement, emphasizing the need for consistent serial assessments over time. Understanding the diverse etiologies of congenital hydrocephalus enables targeted evaluation and appropriate management strategies. Each underlying cause presents distinct clinical patterns and associated findings that guide diagnostic approaches. Dandy-Walker malformation represents a significant cause, with 75% of affected infants developing hydrocephalus. This condition results from abnormal rhombencephalon development between 7 and 10 weeks gestation, creating the characteristic triad of posterior fossa enlargement, fourth ventricular cystic transformation, and cerebellar vermis abnormalities. The associated hydrocephalus often presents early and may require intervention even in the neonatal period. Chiari II malformation shows nearly universal association with myelomeningocele, creating a complex clinical scenario requiring multidisciplinary management. The abnormal hindbrain development, characterized by small posterior fossa, low-lying transverse sinuses, and cerebellar vermis herniation below the foramen and magnum, creates obstructive hydrocephalus. Importantly, head size may initially appear normal or even small due to CSF decompression into the myelomeningocele sac, but rapid expansion often occurs after surgical closure. Neural tube defects, particularly myelomeningocele, show hydrocephalus development in 80 to 90% of cases. This high association rate makes hydrocephalus monitoring essential in all infants with open spinal dysraphisms. The mechanism involves both the underlying Chiari II malformation and potential complications from surgical closure. Torch infections create unique clinical presentations, with toxoplasmosis capable of causing microcephaly even in the presence of hydrocephalus. Cytomegalovirus infection can lead to leptomeningeal and cerebral necrosis, resulting in dystrophic calcifications in the basal ganglia and periventricular regions, white matter lesions, and subsequent hydrocephalus development. These infections require specific diagnostic approaches and may benefit from targeted therapies. Genetic syndromes encompass various chromosomal abnormalities that can include hydrocephalus as part of broader malformation complexes. These associations emphasize the importance of comprehensive genetic evaluation in affected infants. Vascular malformations, particularly vein of Galen malformations, present unique challenges with hydrocephalus occurring alongside high-output congestive heart failure. These rare lesions arise during the third trimester from persistent embryonic vascular structures and require specialized neurovascular expertise for optimal management. Understanding the diagnostic approach to hydrocephalus requires thinking systematically about when and how we gather information to confirm our clinical suspicions. The diagnostic journey often begins before birth and continues with increasingly sophisticated imaging techniques that help us understand both the presence and underlying cause of the condition. Prenatal diagnosis starts with recognizing ventriculomegaly on routine fetal ultrasound examinations. Experienced ultrasonographers can readily identify enlarged ventricles, though they must distinguish this finding from other fluid-filled supratentorial lesions, such as Hydranencephaly or Holoprosencephaly. When uncertainty exists, fetal magnetic resonance imaging provides definitive clarification and superior anatomical detail that helps guide delivery planning and family counseling. The postnatal imaging approach follows a logical progression based on the clinical urgency and the information needed. Cranial ultrasound serves as the first-line imaging modality in neonates because it offers several practical advantages. It can be performed at the bedside without sedation, provides real-time assessment of ventricular size, and allows for serial monitoring over time. This makes ultrasound particularly valuable for tracking progression and guiding treatment decisions. Computed tomography scanning fills an important role when rapid assessment becomes necessary. The speed of CT acquisition makes it ideal for emergency situations where we need immediate confirmation of ventricular enlargement, or when clinical deterioration requires urgent intervention. CT clearly demonstrates ventricular size and can identify complications such as shunt malfunction. Magnetic resonance imaging represents the gold standard for anatomical detail and identification of associated anomalies. MRI provides superior soft tissue contrast that reveals not only the extent of hydrocephalus, but also helps identify the underlying cause. This comprehensive view becomes essential for surgical planning and prognostic counseling with families. The physical examination component requires systematic attention to specific findings that can guide us toward particular etiologies. The thumb flexion deformity characteristic of X-linked aqueductal stenosis appears in approximately 50% of cases and can often be detected even on fetal ultrasound. This seemingly simple finding provides crucial diagnostic information that influences genetic counseling and family planning. Chorioretinitis examination becomes essential when we suspect TORCH infections, particularly toxoplasmosis or cytomegalovirus, as causes of the hydrocephalus. These retinal changes often provide the first clue to an infectious etiology and guide appropriate diagnostic testing and treatment decisions. Occipital prominence examination helps identify Dandy-Walker malformation, where posterior fossa enlargement creates a characteristic external appearance. This finding, combined with appropriate imaging, confirms the diagnosis and helps predict associated complications. The search for associated malformations requires comprehensive evaluation because hydrocephalus rarely occurs in isolation. Systematic examination can reveal additional anomalies that point towards specific genetic syndromes or environmental causes, fundamentally changing our approach to management and family counseling. Managing congenital hydrocephalus requires individualized approaches, progressing from temporary stabilization to permanent cerebrospinal fluid diversion. Treatment decisions must consider the infant's size, medical stability, underlying condition, and overall prognosis. Temporary measures provide crucial bridges to definitive treatment, particularly in premature infants too small for permanent intervention. Serial ventricular reservoir TAPs offer controlled CSF removal. And importantly, research demonstrates that repeated tapping does not increase infection risk when performed properly. This finding has reduced clinical concerns about multiple procedures while allowing careful monitoring. Ventriculosubgaleal shunts represent another temporary solution specifically designed for premature infants. This procedure diverts cerebrospinal fluid to the subgaleal space where it's gradually absorbed, reducing the need for daily aspiration compared to reservoir systems. Studies show similar complication rates and eventual permanent shunt requirements between ventriculosubgaleal shunts and ventricular access devices. Endoscopic third ventriculostomy works well in selected cases by creating alternative CSF flow pathways. This procedure bypasses obstructed routes by making a small opening in the third ventricle floor, though success depends heavily on the underlying cause and patient age. Permanent cerebrospinal fluid diversion most commonly involves ventriculoperitoneal shunt placement, diverting CSF from lateral ventricles to the peritoneal cavity for absorption. Timing depends on progression rates, clinical symptoms, and medical stability. Recent evidence increasingly favors earlier intervention, as progressive ventricular enlargement may predict worse neurodevelopmental outcomes. Shunt complications require ongoing vigilance. Infections occur in approximately 5 to 7.5% of cases, with rates significantly reduced through specific surgical protocols, including antibiotic prophylaxis and refined sterile techniques. Malfunction can result from obstruction, disconnection, or mechanical failure, demanding prompt recognition and intervention. Overdrainage represents another complication where excessive CSF removal causes headaches, subdural collections, or slit ventricle syndrome. Modern programmable shunts address this through non-invasive pressure adjustments based on clinical needs. Monitoring combines regular head circumference measurements plotted on growth curves with clinical assessment of developmental progress, feeding patterns, and neurological function. Periodic ultrasound examinations assess ventricular size and shunt function, with frequency determined by clinical stability. Any concerning symptoms warrant immediate evaluation, as ventricular dilation typically precedes rapid head growth changes. Anencephaly represents the most devastating neural tube defect and the most severe disorder of anterior neural tube closure. Understanding this condition's pathophysiology helps us recognize both its clinical significance and the critical importance of prevention strategies. The developmental failure occurs within the first 4 weeks of gestation, specifically by day 24 when the anterior neuropore fails to close properly. This critical embryological window explains why anencephaly represents an early neurulation defect that establishes the devastating consequences before many women even realize they're pregnant. The pathological process involves failed anterior closure, where exencephaly initially develops, then converts to anencephaly through degradation of exposed neural tissue. This progression results in absent cranial vault and complete absence of functional brain tissue above the level of the orbits, with only disorganized vascular tissue remaining in the area cerebrovasculosa. Anencephaly accounts for roughly half of all open neural tube defects, making it a significant contributor to the overall burden of these conditions. The current incidence stands at approximately 0.28 per 1,000 births, representing a substantial decrease from historical rates due to improved prevention and prenatal detection. The association with polyhydramnios occurs because of poor fetal swallowing mechanisms. Without intact brainstem function controlling swallowing reflexes, amniotic fluid accumulates excessively, often providing the first prenatal clue to the underlying condition. The prognosis remains uniformly fatal, with anencephaly being completely incompatible with life beyond the neonatal period. Most neonates are stillborn, and those born alive typically survive less than 1 to 2 months at most. Without intensive care support, survival beyond the immediate neonatal period has never been reported, making early recognition crucial for appropriate counseling and care planning. This devastating outcome underscores the paramount importance of primary prevention through maternal folate supplementation, which can prevent 60 to 70% of neural tube defects when implemented properly during the periconceptional period. The clinical presentation of anencephaly creates both diagnostic clarity and significant management challenges. Understanding the physical findings helps clinicians provide appropriate immediate care while supporting families through this devastating diagnosis. Physical findings show the characteristic absence of cranial vault above the orbits, creating the pathognomonic appearance that makes anencephaly readily recognizable at birth. The exposed neural tissue, termed area cerebrovasculosa, consists of disorganized, vascularized glial tissue that represents the remnants of what should have been normal brain development. The presence of intact meninges and skull distinguishes anencephaly from hydranencephaly, an important differential consideration. While facial features may appear surprisingly normal, the dramatic absence of the upper cranial structures creates an unmistakable clinical picture. Immediate management focuses on comfort care and comprehensive family support. Protection of exposed neural tissue becomes a priority to prevent additional trauma or infection, though this represents palliative rather than curative intervention. The tissue requires gentle handling and appropriate covering to maintain dignity while providing basic comfort measures. Palliative care discussions must begin immediately, addressing the reality that anencephaly is incompatible with meaningful survival. These conversations require exceptional sensitivity, helping families understand the condition while supporting their emotional needs during this traumatic time. Prenatal diagnosis capabilities provide crucial opportunities for informed decision-making. Fetal ultrasound can readily detect anencephaly after 12 weeks gestation, allowing families time to process the diagnosis and make decisions about pregnancy continuation. The condition's clear ultrasound appearance makes accurate prenatal diagnosis highly reliable. Prevention through maternal folate supplementation represents the most powerful intervention available. When women receive adequate folate during the periconceptional period, the risk of neural tube defects decreases by 60 to 70%, making this simple intervention one of public health's greatest successes in preventing birth defects. Hydranencephaly represents a rare but devastating congenital anomaly characterized by almost complete absence of cerebral hemispheres. Understanding its pathophysiology helps distinguish it from other conditions and guides appropriate clinical management decisions. The underlying mechanism involves a major in utero vascular insult occurring during the second trimester of pregnancy. Bilateral occlusion of the carotid arteries represents the most common cause, though other vascular catastrophes can produce similar results. The timing of this insult proves critical, as it occurs after basic brain formation has begun, but before the brain achieves structural maturity. Following the vascular insult, the brain undergoes intrauterine liquefaction, essentially destroying the cerebral hemispheres while leaving deeper structures intact. This process transforms what should have been functional brain tissue into a fluid-filled cavity, creating the characteristic bag of water appearance that gives the condition its name. Remarkably, specific brain structures remain preserved despite the devastating hemispheric loss. The diencephalon, including the thalami, survives because these structures receive blood supply from the posterior circulation, which remains intact. Similarly, brainstem and posterior fossa structures continue functioning normally, explaining why affected infants can initially appear neurologically normal. A thin occipital cortical rim may persist in some cases, potentially permitting some residual visual function. However, this represents minimal preserved tissue compared to the massive loss of cerebral hemispheres that normally provide higher cognitive functions. The end result transforms the brain into essentially a meningeal sac containing cerebrospinal fluid with unusually high protein content. This proteinaceous CSF creates absorption problems that often lead to progressive head enlargement, adding a secondary complication to the primary developmental abnormality. This pathophysiology explains the clinical course where infants may initially seem normal due to preserved brainstem and diencephalic function, but inevitably fail to achieve meaningful developmental milestones as the absence of cerebral hemispheres becomes functionally apparent. The clinical presentation of hydranencephaly follows a characteristic pattern that initially masks the severity of the underlying condition. Understanding this progression helps clinicians recognize the diagnosis and provide appropriate family counseling. During the neonatal period, affected infants may appear remarkably neurologically normal at birth due to the preserved function of thalami and brainstem structures. These deep brain structures control basic vital functions, including breathing, heart rate, and sleep-wake cycles, allowing the infant to maintain physiological stability despite the absence of cerebral hemispheres. Early neurological assessment may reveal subtle abnormalities, particularly difficulty with visual fixing and following behaviors. This finding reflects the absence of cortical visual processing areas, though the significance may not be immediately apparent to clinicians or families expecting more dramatic presentations. Head size characteristics show interesting patterns. The head may appear normal or even small initially because the absent brain tissue reduces intracranial volume. However, this apparent normalcy becomes deceptive as the clinical course progresses. The progressive course reveals the condition's true severity. Rapid head enlargement develops due to malabsorption of the proteinaceous cerebrospinal fluid that fills the space where brain tissue should exist. The high protein content of this fluid impairs normal absorption mechanisms, causing progressive accumulation and head growth. Developmental failure becomes increasingly apparent as infants fail to achieve expected milestones. The absence of cerebral hemispheres makes normal cognitive, motor, and social development impossible, though the timeline for recognition varies among families and healthcare providers. Diagnosis often occurs after several months when developmental delays become undeniable and head enlargement becomes pronounced. This delayed recognition can create additional emotional trauma for families who initially believed their infant was developing normally. The key clinical distinction from severe hydrocephalus becomes crucial for management decisions. In hydrocephalus, compressed cerebral tissue may expand dramatically after shunting, potentially recovering function. In hydranencephaly, no recoverable brain tissue exists, making interventions futile for neurological improvement. Diagnostic approaches for hydranencephaly require understanding the strengths and limitations of different imaging modalities. Management decisions must balance technical possibilities with realistic outcomes and family values. Imaging capabilities vary significantly in their diagnostic accuracy. Ultrasound can suggest the diagnosis by demonstrating the absence of normal brain tissue and the presence of large fluid-filled spaces. However, ultrasound may not provide the definitive anatomical detail needed for certain diagnosis, particularly in distinguishing hydranencephaly from severe hydrocephalus. Magnetic resonance imaging provides the most accurate definitive diagnosis by clearly demonstrating the complete absence of cerebral hemispheres while showing preserved thalami, brainstem, and posterior fossa structures. MRI's superior soft tissue contrast makes it the gold standard for confirming the diagnosis and ruling out other conditions with similar presentations. Management considerations present complex ethical and practical challenges. Shunting procedures for progressive macrocephaly remain technically possible, but serve primarily to ease caretaking rather than provide neurological benefit. The decision to proceed with shunting becomes difficult because it does not improve brain function or developmental potential. The primary benefit of shunting involves making physical care more manageable for families and caregivers. Reducing head size can facilitate positioning, feeding, and general handling, potentially improving quality of life from a comfort perspective. However, families must understand that shunting provides no neurological improvement or developmental benefits. Decision-making regarding interventions requires careful consideration of family values, cultural factors, and individual circumstances. Some families may choose aggressive interventions to maximize survival time, while others prefer comfort-focused approaches that prioritize quality over quantity of life. The prognosis remains consistently poor, regardless of interventions. Most infants with hydranencephaly do not survive beyond 1 to 2 years, and survivors face profound developmental disabilities with no potential for meaningful neurological recovery. Family counseling must focus on comfort care principles and quality of life considerations. Supporting families through this devastating diagnosis requires honest communication about limitations while respecting their values and decisions about care approaches. Holoprosencephaly represents a spectrum of severe forebrain malformations resulting from failure of prosencephalon cleavage into paired hemispheres. Understanding this condition requires recognizing it as the most common brain malformation, though most affected fetuses are lost early in pregnancy. The incidence demonstrates the condition's severity, occurring in approximately 1 in 16,000 live births, but rising dramatically to 1 in 10,000 when pregnancy losses are included. This difference reflects the high rate of early embryonic death, with incidence reaching 40 per 10,000 when embryos are included in studies. The DeMeyer classification system provides the framework for understanding holoprosencephaly's severity spectrum. This classification correlates directly with prognosis and helps guide family counseling and treatment decisions. Alabar holoprosencephaly represents the most severe form, characterized by a single ventricle and complete absence of hemispheric separation. The prosencephalon fails to divide, creating a holosphere with no interhemispheric fissure, corpus callosum, or third ventricle formation. Semilobar holoprosencephaly shows partial separation with the posterior interhemispheric fissure present while anterior fusion persists. This intermediate form demonstrates some hemispheric development but maintains significant structural abnormalities. Lobar holoprosencephaly represents the least severe variant with nearly complete hemispheric separation and only mild frontal fusion remaining. Most normal brain structures develop, though frontal lobe abnormalities persist. The middle interhemispheric variant, also called scintillencephaly, affects the posterior frontal and parietal regions while sparing other areas. This form may not be recognized in the neonatal period unless diagnosed prenatally. The Alabar form represents the most devastating presentation of holoprosencephaly, characterized by complete failure of prosencephalic separation. Understanding these characteristics helps clinicians recognize the condition and provide appropriate counseling about prognosis. Brain characteristics demonstrate the severity of developmental failure. The single anterior ventricle, termed a monoventricle, replaces the normal paired lateral ventricles. This represents complete absence of hemispheric division with no separation of prosencephalic structures. Critical midline structures fail to develop properly, including absent corpus callosum, anterior commissure, and septum pellucidum. These structures normally connect and separate the hemispheres, and their absence reflects the fundamental failure of brain cleavage. Deep brain structures show extensive fusion, with thalami and hypothalamus forming continuous masses rather than paired structures. This fusion disrupts normal neural circuitry and contributes to the severe functional deficits observed in affected infants. The olfactory system demonstrates severe abnormalities, with absent or hypoplastic olfactory bulbs and tracts, creating the condition called Anencephaly. This finding often accompanies the most severe facial anomalies and provides additional clinical evidence of the developmental failure. Associated features frequently include large posterior dorsal cysts that communicate with the ventricular system. These cysts form from CSF accumulation and may contribute to progressive head enlargement. Hydrocephalus commonly develops due to fused thalami blocking normal cerebrospinal fluid flow pathways. The anatomical disruption prevents normal CSF circulation, leading to progressive ventricular enlargement that may require surgical intervention. The most severe facial anomalies typically accompany alobar holoprosencephaly, following the principle that face predicts brain. The severity of facial malformation correlates directly with the degree of brain abnormality, providing important prognostic information. The milder forms of holoprosencephaly demonstrate partial preservation of normal brain development, though significant abnormalities persist. Understanding these forms helps clinicians distinguish severity levels and provide appropriate prognostic counseling. Semilobar characteristics show the transitional nature between complete fusion and normal separation. Partial hemispheric separation occurs posteriorly, while anterior fusion of frontal lobes exceeds 50% of normal development. This pattern creates a mixed presentation with some normal and some abnormal brain regions. The interhemispheric fissure demonstrates partial development, forming posteriorly but remaining absent anteriorly. This incomplete separation reflects the developmental arrest that occurs during prosencephalic cleavage. Corpus callosum development shows partial preservation with rudimentary formation posteriorly, though anterior portions remain absent. This limited development may provide some interhemispheric communication while maintaining significant functional deficits. Deep nuclear structures display incomplete separation, with thalami and other structures showing variable degrees of fusion. This partial separation may preserve some normal function while maintaining significant abnormalities. Lobar characteristics represent the mildest form with nearly complete hemispheric separation achieved. The interhemispheric fissure forms along most of the midline, creating more normal brain architecture. Corpus callosum development shows well-formed posterior portions, while anterior components may remain underdeveloped. This pattern provides better interhemispheric connectivity than more severe forms. Ventricular system development demonstrates partial normalization with third ventricle presence and partially formed frontal horns. Though abnormal, these structures provide better CSF circulation than more severe forms. The primary abnormality in lobar holoprosencephaly involves hypoplastic frontal lobes, which may be the only obvious structural finding. However, this seemingly mild abnormality can still produce significant functional deficits in executive function and behavior. The relationship between facial anomalies and brain malformation in holoprosencephaly follows the fundamental principle that face predicts brain. Understanding this correlation helps clinicians assess severity and provide prognostic information to families. The cyclopia spectrum represents the most severe facial manifestations, correlating with allobar holoprosencephaly. Cyclopia involves a single central eye with a proboscis above, reflecting complete failure of facial development. This devastating abnormality indicates the most severe brain malformation. Synophthalmia presents with fused orbits creating partially separated eyes within a single socket. Though slightly less severe than cyclopia, this finding still indicates profound brain abnormalities and poor prognosis. Complete absence of nasal structures accompanies the most severe forms, reflecting the developmental relationship between forebrain and facial development. The absence of normal midline facial structures mirrors the absence of normal brain separation. Intermediate severity presentations include sebocephaly, characterized by a flattened single nostril positioned between the eyes. This finding indicates significant but not complete developmental failure, typically correlating with severe brain abnormalities. Severe hypotelorism with proboscis represents another intermediate finding where the eyes remain too close together with abnormal nasal development. These patients typically have semilobar or severe lobar holoprosencephaly. The mildest facial forms may show only hypotelorism without other obvious abnormalities. While appearing relatively normal, these subtle findings can still indicate significant brain malformation requiring careful evaluation. Single central incisor represents a common mild facial marker that may be the only obvious abnormality. This finding warrants brain imaging as it can indicate lobar holoprosencephaly even when other features appear normal. Median cleft lip and palate complete the spectrum of facial findings, ranging from obvious malformations to subtle abnormalities that require careful examination to detect. The complications associated with holoprosencephaly extend beyond the primary brain malformation, affecting multiple organ systems and requiring comprehensive management approaches. Understanding these complications helps clinicians provide appropriate care and family counseling. Endocrine abnormalities occur very commonly due to hypothalamic and pituitary dysfunction. The failure of normal prosencephalic development disrupts the hypothalamic-pituitary axis, creating complex hormonal deficiencies that require ongoing management. Diabetes insipidus affects up to 70% of patients, representing the most common endocrine complication. The inability to concentrate urine properly creates fluid balance challenges that require careful monitoring and treatment with desmopressin. Additional hormonal deficiencies include hypothyroidism and hypoadrenocorticism, though these occur less frequently than diabetes insipidus. Growth hormone deficiency contributes to poor growth and development in affected children. Severe cases may develop panhypopituitarism with complete absence of pituitary function. This devastating complication requires comprehensive hormone replacement therapy and complex medical management. Temperature dysregulation reflects hypothalamic dysfunction, creating problems with maintaining normal body temperature. This complication complicates nursing care and may contribute to increased morbidity. Inappropriate antidiuretic hormone secretion can occur, creating the opposite problem from diabetes insipidus. This condition requires careful fluid management to prevent dangerous electrolyte imbalances. Neurological manifestations affect approximately 40% of patients with seizures, though 1/3 of these develop intractable epilepsy. The abnormal brain architecture creates seizure foci that may be difficult to control with medications. Stimulus-sensitive tonic spasms represent a characteristic seizure type in severe cases, often triggered by handling or environmental changes. These spasms may be difficult to distinguish from normal movements in newborns. Apneic spells reflect brainstem dysfunction and create life-threatening respiratory complications. These episodes require careful monitoring and may necessitate respiratory support. Hypotonia and profound developmental delays accompany all forms, though severity correlates with the degree of brain malformation. Early intervention programs may help optimize development within the constraints of the underlying condition. Understanding the diverse causes of holoprosencephaly helps clinicians provide appropriate genetic counseling and guides evaluation of affected families. The etiology encompasses chromosomal, genetic, and environmental factors. Chromosomal abnormalities account for 25 to 50% of cases, representing the most common identifiable cause. These large-scale genetic alterations disrupt multiple developmental pathways simultaneously, often creating severe malformations. Trisomy 13 shows the strongest association, with 70% of affected individuals developing holoprosencephaly. This high correlation makes holoprosencephaly one of the characteristic features of trisomy 13 syndrome, emphasizing the importance of chromosomal analysis in affected infants. Trisomy 18 and triploidy also associate with holoprosencephaly, though less frequently than trisomy 13. These chromosomal abnormalities typically create multiple congenital anomalies in addition to the brain malformation. Deletion syndromes involving multiple genes can disrupt the complex developmental pathways required for normal prosencephalic cleavage. These microdeletions may not be detectable on standard chromosomal analysis, requiring more sophisticated genetic testing. Single gene mutations account for approximately 10% of cases, involving genes critical for early brain development. The sonic hedgehog gene represents the most commonly mutated single gene, reflecting its central role in prosencephalic development. ZDI-C2, SYX3, and TGIF genes represent additional important single gene causes, each contributing to the complex developmental cascade required for normal brain formation. Mutations in these genes can cause familial cases with variable penetrance and expression. Environmental factors include maternal diabetes, which increases the risk of holoprosencephaly through unknown mechanisms. Proper diabetic control during pregnancy may reduce this risk. Ethanol exposure during critical developmental windows can disrupt normal prosencephalic cleavage. This preventable cause emphasizes the importance of avoiding alcohol during pregnancy. Smith-Lemli-Opitz syndrome, a cholesterol metabolism defect, demonstrates how metabolic abnormalities can disrupt normal brain development. This association highlights the complex biochemical requirements for normal embryogenesis. Most cases remain sporadic with low recurrence risk, providing reassurance to families about future pregnancies. However, genetic counseling remains important to identify the small percentage of cases with hereditary causes. Management of holoprosencephaly requires a multidisciplinary approach addressing the complex medical needs while supporting families through difficult decisions. Understanding the prognosis helps guide appropriate care planning and resource allocation. Acute management focuses on addressing life-threatening complications and providing supportive care. Ventriculoperitoneal shunt placement for hydrocephalus provides symptom relief by reducing intracranial pressure, though it doesn't improve neurological function. Endocrine evaluation and replacement therapy become essential for managing the common hormonal deficiencies. Diabetes insipidus treatment with desmopressin helps maintain fluid balance, while thyroid and adrenal hormone replacement address other deficiencies. Seizure management requires careful medication selection and monitoring, as many patients develop intractable epilepsy. Multiple anti-epileptic drugs may be necessary, and some seizures remain refractory to treatment despite aggressive therapy. Feeding support often requires tube feeding due to poor coordination of sucking and swallowing reflexes. Gastrostomy tube placement may become necessary for long-term nutritional support in severely affected infants. Prognosis varies significantly by severity, with allobar forms carrying the worst outlook. Many infants with allobar holoprosencephaly do not survive the first year of life due to the severity of brain malformation and associated complications. Semilobar and lobar forms may allow survival to early adulthood, though severe developmental disabilities remain universal. These patients require lifelong supportive care and typically achieve minimal developmental milestones. Quality of life considerations become central to care planning discussions. Families must weigh the burdens of intensive medical interventions against realistic expectations for meaningful neurological improvement. Family counseling requires exceptional sensitivity and ongoing support. Genetic counseling and testing help identify hereditary causes and guide family planning decisions for future pregnancies. Multidisciplinary care coordination involves neurology, endocrinology, genetics, and other specialists working together to address the complex medical needs. Social work support helps families navigate the healthcare system and access community resources. The focus shifts toward comfort care and family support when aggressive interventions offer little benefit. Palliative care principles help maintain dignity while addressing symptoms and supporting the family through this devastating diagnosis.